Good afternoon. Thank you all for joining us for our web event looking at Medicaid and CHIP policies as states prepare for the unwinding of the continuous enrollment provision. We are thrilled that so many people were able to join us for this really important discussion. We have a lot to cover in the next hour, but before we get to the substance, I want to go over a few logistics. First, the briefing is being recorded and a link to the recorded version will be emailed to everyone later today. Second, we have ASL interpretation available. To access it, please click on the globe icon in your Zoom control panel and select American Sign Language. A screen will appear and you will be able to view the interpreter. And finally, we will be saving time for your questions. So please enter questions using the Q&A function at any time during the discussion. So let's get started. I am finding it quite fitting that we're holding this briefing on the kickoff to March Madness basketball, because getting ready to unwind the Medicaid continuous enrollment provision that has been in effect for the last 3 years definitely qualifies as a much different kind of March Madness, but with very high stakes as coverage for millions of Medicaid enrollees hangs about. A KFF analysis shows that by the end of March, Medicaid and CHIP enrollment will be close to 95 million people, an increase of 23 million since prior to the pandemic. During the unwinding, estimates show that millions could lose coverage if they are no longer eligible, but also if they remain eligible and face barriers renewing their coverage. We heard during recent focus groups that many Medicaid enrollees have experienced worsening health and financial stability during the pandemic. But we also heard that Medicaid coverage is affordable and has helped people access needed health care. Most enrollees in our groups were not aware that Medicaid coverage had been protected during the pandemic, and they were also not aware that disenrollments could start as early as April. These findings suggest the need for ongoing efforts to conduct outreach and communication about the upcoming renewals. In preparation for the unwinding, a lot of activity is already underway. CMS has been working to provide guidance to states, while states are working to adopt and implement policies to get ready for the unwinding. In addition, managed care plans, providers, and enrollment assisters are gearing up to help people navigate their renewals. Earlier today, in collaboration with the Georgetown Center for Children and Families, CCF, we released our 21st annual survey of state Medicaid and CHIP eligibility, enrollment, and renewal policies, showing what policies were in place as of January 2023. The survey also presents a snapshot of the action states are taking to prepare for the unwinding of the continuous enrollment provision. This report is a huge team effort. We really want to thank all the states who took time to participate in the survey. We are always grateful for state participation, but even more so this year because we were in the field just as legislation ending the continuous enrollment provision was passed at the end of 2022. So it was and continues to be an extremely busy time for state officials. I also want to recognize the staff at KFF and CCF who worked on the substance of the report, but also our communications and productions teams who helped to organize this webinar and get the report posted and disseminated. Finally, I want to thank our amazing panel of experts. We are really looking forward to hearing from Jennifer Tolbert from KFF and Tricia Brooks from CCF, who will walk us through some high-level findings from the annual survey. And then we will turn to more of a discussion with a panel to offer a range of perspectives from the federal government, the states, and on the ground. We are looking forward to hearing from Jessica Stevens, a senior policy advisor in the Office of the Center Director for the Center for Medicaid and CHIP Services at CMS, Kate McAvoy, the Executive Director for the National Association of Medicaid Directors, and Tia Whitaker, who is the statewide Director of Outreach and Enrollment for the Pennsylvania Association of Community Health. So with that, I will turn it over to Jen and Tricia to go over some findings.
Great, thanks, Robin. So while Tricia Brooks and I are presenting findings from the report, I do want to take a minute to acknowledge the rest of the incredible team that made this work possible. Alexa Gardner and Peyton Gee at Georgetown Center for Children and Families, and Brad Corallo, Sophia Moreno, and Anna Mula here at KFF. And as Robin noted, we simply could not do this work without our state partners, and we especially appreciate their participation this year. So thanks to you all. Now let's dig into the findings. Great, thank you. With the continuous enrollment provision ending on March 31st. After months of preparing, states are actually beginning the unwinding process. Under CMS guidance, states had the option to initiate the first batch of the renewals, or in other words, begin the unwinding period in February, March, or April. And according to our survey data, as well as data from CMS, 8 states started this process in February, 15 states started this month, and 28 states will begin in April. And now, while states can begin disenrolling people as early as April, as a general rule, we can expect to see disenrollments about 60 days after renewals have been initiated, given federal notice requirements. So that means we begin to see disenrollments in April for states that started in February, but not until June for states that started the process or that will begin the process in April. Next slide, please. So CMS guidance permits states to take up to 12 months to initiate and 14 months to complete all renewals during the unwinding period. And most states, 43 in total, plan to take the full time to process all renewals. However, some states are planning to move a bit more quickly. Spreading renewals over a longer period will enable states to better balance the volume of renewals with the capacity of both staff and their systems to process those renewals. Next slide, please. So states that have continued processing renewals while the continuous enrollment provision has been in place have been able to flag individuals who appear to no longer be eligible or who did not respond to a renewal request. Importantly, states will still have to complete a full renewal on all enrollees, even if they have information suggesting that someone may no longer be eligible. However, they can use this information to prioritize renewals for these individuals earlier in the unwinding period. And while over half of states reported flagging individuals who may no longer be eligible, only 11 of the reporting states said that they will prioritize renewals for these individuals first during the unwinding period. Most states are instead considering multiple factors in their approach to prioritizing renewals, including factors such as time since last renewal, whether individuals have been utilizing services, and the vulnerability of certain groups. And I should note, some states are also planning to simply process renewals based on an enrollee's current renewal funds. Next slide, please. Federal regulations require states to attempt to renew coverage for enrollees using reliable data sources before requiring an enrollee to complete a renewal form or to submit documentation. Now, these automated renewals are referred to as ex parte renewals. And 43 states reported that they have continued to process ex parte renewals during the past year. Additionally, 30 states indicated that they have taken steps to increase ex parte renewals again over the past year. And that effort does seem to be paying off. 18 states reported that they are able to complete 50% or more of all renewals using ex parte processes. And while that number may still be a little low, it is up from just 11 states last year. Completing higher shares of ex parte renewals can help reduce the administrative burden on both staff and enrollees. Next slide, please. And reducing the administrative burden on staff is really important because many states are facing staffing challenges, including staffing shortages. Over half of reporting states indicated their vacancy rate for frontline eligibility workers exceeds 10%, including 7 states with vacancy rates greater than 20%. States face similar challenges, though slightly less severe, with call center staff. In response, over 2/3 of states have taken steps to boost eligibility staff capacity, including approving overtime and hiring new staff, temporary workers, or contractors. Next slide, please. States face long-standing difficulties in reaching enrollees by mail, which is still the primary method they use to send renewals and other requests for information. One important way that states can reduce disenrollments among people who remain eligible is to make sure they have enrollees' current contact information. That way, when they send out a notice through the mail, it's more likely that the enrollee will receive and act on that notice. So to that end, all states took action over the past year to encourage enrollees to update their mailing addresses and other contact information, including direct outreach to enrollees, as well as checking for updated addresses in SNAP and other benefit programs. States have also made it easier for enrollees to update their information by creating an online change of address form or having a dedicated center. In addition, 40 states reported that they will follow up on returned mail by phone, email, and or text to attempt to locate an enrollee before terminating coverage. Provisions in the Consolidated Appropriations Act require states to make a good faith effort to follow up on returned mail using at least 2 communication modes. I will note that our survey was sent out, as Robin noted earlier, our survey was sent out in mid-December before the CAA was enacted, and many states submitted their survey responses before CMS released more detailed guidance on this issue. So it is possible that more states are now taking steps to follow up on return. Next slide, please. And given the massive undertaking that states have already, in some cases, embarked on and others are beginning to, most states are engaging with key stakeholders, including managed care organizations, to assist with outreach to enrollees. 31 states are accepting updated contact information from MCOs without re-verifying that information with enrollees. And states are also planning to send MCOs advanced lists of members who are due for renewal, members at risk of being disenrolled because they have not responded to a renewal request, as well as members who have been disenrolled that identifies whether the individual was determined ineligible or whether they were disenrolled for procedural reasons. Now, the goal of these efforts is to enable MCOs to do targeted outreach to their members and provide assistance to help members complete the renewal process or transition to other coverage in the marketplace if the MCO also operates a qualified health. And so with that, I will turn it over to Tricia to present additional findings.
We can go to the next slide, please. Thank you, Jen. I'd like to start with highlights of a few actions states are taking to improve the renewal outcomes. States must give MAGI-based enrollees, that's kids, pregnancy, and adults, 30 days to respond to renewal requests, but there's no federal requirement for states to do more than send the renewal form or the request for information. We know that sending reminder notices, as 36 states plan to do, via mail and through other communication modes, including phone, text, and email, can increase the renewal response rate. Follow-up reminders also help reduce the number of people who are disenrolled at the end of the unwinding period because they did not provide needed information. So as you can see here, about a third of states plan to mail a reminder, while about half of the states will text reminders. 2 out of 5 states will send emails or plan to make individual or automated calls. And altogether, over 29 states are planning to use multiple methods to follow up with enrollees. Next slide, please. Online assister portals create administrative efficiencies for states by allowing navigators, assisters, and authorized partners to initiate certain administrative tasks associated with enrollment and renewal. Secure portals also provide a mechanism for states to monitor assister performance. These portals often have many of the same features that are available to enrollees in their online accounts, which almost all states have now. We were pleased to find that 29 states have online assister portals. In most of those states, assisters are able to submit applications and review application status. Assisters can report changes in circumstances in 19 states, view notices in 15 states, view pending actions and submit renewal information in 18 states, and upload documents or update contact information in 20 states. In the report, we also show steps that states are taking to align renewal policies for the MAGI groups with people who have disabilities or dual eligible seniors. As background, many of the streaming renewal rules adopted by the Affordable Care Act did not apply to coverage for people with disabilities or seniors dually eligible for Medicaid and Medicare. CMS has proposed rules that will largely align renewal policies across these groups, but states are a step ahead, with all states taking at least one action to align renewal processes. Next slide, please. Turning now to eligibility, South Dakota will expand Medicaid to adults in July of 2023, making it the 7th state where voters have approved ballot initiatives to adopt Medicaid expansion. And North Carolina is poised to become the 41st state to adopt Medicaid expansion after state legislators reached a deal that is expected to be voted on soon. However, eligibility remains extremely low in the states that have not implemented the Medicaid expansion, with the median income of eligibility dropping from 38.5% of the federal poverty level to 37%. That's just over $9,000 annually for a family of 3. And this is because 8 non-expansion states base income eligibility on dollar thresholds that are not routinely updated. So over time, the equivalent FPL level decreases when the federal poverty threshold is adjusted upward to account for inflation, as it did in 2023 when the FPLs rose an average of 8%. So the erosion is more evident. So for example, Tennessee's parent eligibility declined from 88% FPL in 2022 to 82% in 2023. Next slide, please. Over the past year, several states have taken steps to expand coverage to immigrant children and adults. In 2022, Kentucky removed the 5-year waiting bar for children and pregnant individuals. So as of January of 2023, 40 states use federal funding to extend coverage to some immigrant children and/or pregnant individuals without the 5-year waiting period. This includes 35 states that have adopted the option for children of Medicaid and CHIP, and 26 states that provide pregnancy coverage to lawfully residing individuals. In 2022, Connecticut and Maine adopted the unborn child option and CHIP to provide coverage during pregnancy, regardless of immigration status, bringing the total count of states doing so to 20. States are also increasingly using state funds to extend coverage or limited benefits to some immigrant children, pregnant individuals, and other adults who have no federal pathways to coverage. A dozen states now cover all income eligible children, regardless of immigration status, including Connecticut, Maine, New Jersey, Rhode Island, and Vermont that extended this coverage in 2022. And 11 states use state-only funds to cover immigrant adults who are otherwise ineligible, including Illinois, New Jersey, Oregon, and Vermont that newly extended coverage to targeted immigrant adult groups in 2022. Next slide, please. The pandemic has shown how continuous enrollment stabilizes coverage in Medicaid and CHIP. States have long had the option to provide 12-month continuous eligibility for children, as 33 states do, but that includes 7 states that guarantee full-year coverage only in CHIP. The CAA requires states to provide 12-month continuous eligibility for all children beginning in January 2024. But some states have their sights on longer periods of continuous enrollment for children, particularly during the critical early developmental years when continuous access to care can address developmental delays and support school readiness. In 2022, Oregon became the first state to receive Section 1115 waiver approval to cover children continuously until their 6th birthday. 3 other states, California, New Mexico, and Washington, have similar plans. Oregon also received approval to provide 2-year continuous eligibility for everyone age 6 and older. Illinois is developing a similar proposal to provide 2 years coverage for all enrollees. And would be remiss to not note the rapid take-up of extended coverage for 12 months postpartum in 37 states in about 2 years, with more states considering legislation to do so. Kentucky also expanded income eligibility to cover pregnant adults through CHIP, while Oklahoma is seeking approval to increase pregnancy eligibility of Medicaid. These actions are a clear reflection of the country's increased focus on maternal health and health disparities. Next slide, please. The impact of the unwinding will vary across states, driven by differences in system capabilities, including the rate of ex parte renewals, as well as communication strategies, staff capacity, and adoption of operational policies that make it easier for people to stay enrolled. Even with many states taking steps to promote continuity of coverage, millions are expected to lose their health insurance. And after achieving historically low rates of uninsurance, it is likely that the uninsured rate will increase as states resume Medicaid disenrollments. Now, we know that most people who are disenrolled from Medicaid because they're no longer eligible should have a path to other coverage options through the marketplaces or an employer. But even with zero premium ACA plans available for some, affordability and limited special enrollment periods may remain a barrier for others. Still, disenrollments for procedural reasons are expected to be high. The Office of the Assistant Secretary for Planning and Evaluation estimated that 45% of people disenrolled during the unwinding will lose coverage despite remaining eligible. And this will disproportionately impact children and people of color. Boosting staff resources, actively monitoring the unwinding to identify issues, and rapidly responding to systemic or recurring problems can help avoid procedural disenrollments that lead to coverage losses. Nonetheless, after achieving historic coverage levels, it is likely the uninsured rate will rise again. And beyond the unwinding, in the coming year, Medicaid agencies will continue to be stretched as the Biden administration works to finalize rules and policy to help promote and expand coverage. At the same time, congressional debate over the debt ceiling has given rise to talks of cuts to Medicaid and other assistance programs. Interest in putting restrictions on Medicaid enrollment, such as work requirements, have resurfaced, as well as strategies to slow the growth in Medicaid spending that largely shifts increasing cost onto the states by putting constraints on federal funding. How serious this debate is remains to be seen. And on that note, I'll pass it back to Robin.
Thank you so much, Jen and Tricia, for the great overview of so much information that's included in the report. So now, as promised, I want to turn to our panel discussion and hear their perspectives on what's happening with unwinding. So I want to start with a pretty high-level question and going to ask our panel if they could talk about how you or your organization have been helping states or enrollees prepare for the unwinding, and maybe highlight some of the key actions that you were taking. And maybe we could start with Jessica on that one.
Sure. Thanks, Robin. And thanks to all of you for this great report. It really highlights, I think, some of the work that states have been doing and that we at CMS have been doing over the past now 2+ years to prepare for the unwinding. And from the CMS perspective, we really think about this as an all-of-government approach and have bucketed our work in what we like to think about as 3 different areas, right? The first is minimizing churn. As we've talked about, and I think as you've highlighted, states are really thinking about all of the work that they will need to do to renew and redetermine eligibility. The primary goal is to ensure that people who are eligible retain coverage. And we've been doing that by providing policy guidance, by providing tools. If anybody has seen the medicaid.gov/unwinding page, we have put out a multitude of tools over the past couple of years to help both states and stakeholders prepare for the unwinding period. And that includes as well the work that we plan to do in the future around data monitoring and oversight. Our second bucket involves transitions of coverage. So ensuring that smooth transitions of coverage occur for people who are no longer eligible for Medicaid. And that includes not only coverage to the marketplace, but there will be lots of children in particular who may no longer be eligible for Medicaid and continue to be eligible for CHIP, or individuals who may no longer be eligible for Medicaid, but now may be eligible for Medicare. It is critical from our perspective to ensure that those transitions happen in a smooth fashion to ensure that people who continue to be eligible aren't lost from coverage. I know there's been a lot of talk about sort of the numbers of people who are expected to lose coverage. That does not necessarily need to equate to the number of people who become uninsured. And then I think the third bucket of work that CMS and federal government overall have been focused on really has to do with outreach and engagement. Both on what to expect, what can be done now, and on an ongoing basis, the targeted outreach and education work that I think we've been trying to do and will continue to do in the coming months to ensure that eligible people know what they need to do to keep their coverage and what those need to do to transition. Right now, CMS is working on their campaign referred to as Don't Wait Update. I heard Tricia talk about updated contact information, which is going to be critical. Soon we'll have further updates, including things like social media, digital campaigns, transit ads, et cetera. And some of the tools that we've released, including toolkits, are intended to help support both state outreach efforts and also the work of many community partners as well.
Terrific. Thank you so much. Kate, how about we hear a little bit about what the perspective is from the states?
Yes, thank you so much. Just echoing Jessica, this report is an absolute wealth of information, very of the minute. So thank you so much for Kaiser's leadership in this area. I also want to build on what Jessica said when she talked about an all-of-government approach. That is encompassing in the framework of a federal-state partnership, the longstanding partnership of state and federal actors in operating the Medicaid program. So we are all in linking arms on those aspects that Jessica discussed. I would say from the NAMD lens, just amplifying a kind of predominant focus is on raising awareness, not only of the reality and the challenges of the unwinding process, but to Tricia's point around the foundational importance of Medicaid benefits to millions of folks nationwide at this time where there may be existential threats. So raising awareness is a key aspect I think our association is very concerned with. We also are actively partnering with CMS to translate the guidance that it is issuing to states, acting as an intermediary for not only doing that, but offering as a sort of real-time basis feedback on the state experience with operationalizing the expectations, especially as states navigate the staged process towards compliance with all of the rules around eligibility processing. And finally, NAMD has convened and maintains very close contact with several affinity groups representing individuals across our membership in several domains that are really important to this unwinding effort. First, eligibility and enrollment leads from state programs. Second, communications officers, and also very notably, chief fiscal officers. Really, the effort is to acknowledge that this is a multifaceted effort encompassing different domains of the work of state government, really bringing folks together to synthesize the work, to improve communication, and really to drive toward that common goal of retention of coverage for all eligible folks.
Great. And Tia, I think you're closest to the ground and working with enrollees. So can you tell us a little perspective from what?
From our perspective, we see that it is extremely important to share clear, concise communication and do it often to help to prepare our Medicaid recipients, our community health centers, our patients, and community organizations for the unwinding and all of the changes that are going forward. We're working very closely with the Department of Human Services in the state of Pennsylvania, and in conjunction with Penny, our state-based marketplace, and many community organizations. We've been collaborating and working regularly, both local and regionally, to ensure that we're all utilizing and saying the same message and communicating the most important information and the most important points so that we don't have folks who are slipping through the cracks. Our messaging consists of, there's no wrong door for enrollment assistance in Pennsylvania. Community Health Center enrollment assisters can assist with clarification of notices, renewals, and enrollments directly through our Department of Human Services system, which is called Compass. So we're making sure we're filling in the gaps, going from the state and federal level right down to the boots who are on the ground. And we're highlighting the role of health insurance enrollment assisters at our network of community health centers in all of our locations, and letting folks know we're not only connecting them to quality health insurance, but we're connecting them to quality care, and that we're available during periods of insurance and uninsured.
Just to build on that a little bit, I'm wondering if we could stay with you and if you can talk a little bit about what you see the biggest challenges are on the ground in terms of what enrollees and providers are faced with in this as they start this process.
So one of the biggest challenges we see, of course, are consumers who are not receiving their notices or understanding their notices when it comes to the renewals. Another challenge we see is the sheer number of renewals that will be coming over the next 12 months. Pennsylvania has over 3.6 million Medicaid recipients who will be renewing, and close to 1 million, if not over 1 million folks who are likely ineligible or will be deemed ineligible at the end of the public health emergency. Another challenge we see will be accessing the data to know who's actually ineligible and providing proactive assistance.
Great. I know that the Medicaid directors, of course, will have many challenges ahead of them, and I'm wondering if you could maybe highlight a few of what you think the biggest challenges are there.
So really with the Medicaid directors, sheer volume.
Kate, I'm sure you want to add on to
Sure, yes.
long list of Medicaid director challenges.
And Tia, I absolutely resonate. I mean, volume is a very serious challenge. Obviously, this is an unprecedented volume of work within a defined period of time. I will say Medicaid programs have actively been preparing for over a year, developing very detailed, multifaceted operational plans that touch on major aspects of communications, engagement with members and providers, and really the operational nuts and bolts. I do absolutely resonate with what Tia said about just the sheer numbers will definitely tax systems that are accustomed to doing this on a more staged basis. I think also the piece on which Tia dwelled around public literacy, just playing that out a little bit, folks with very complex life circumstances who are served by Medicaid have a lot of demands in their lives, tracking to those formal communications that have been the sort of norm for Medicaid programs. Medicaid directors are very aware of the need to approach this in a different way that will meet people where they are, for instance, through texting. So examining and operationalizing those different ways of connecting through text and email, and really looking at ways to intersect with how people receive information kind of in their daily lives through their trusted partners in the community. I think that is a central challenge at this stage of the unwind. Ongoing, I think another major challenge is to remain vigilant about progress and emerging themes where there may be challenges that we can make observations about nationally, from which states can learn best practice from their peers. So those are the areas I think we'll really be tracking.
Great. And I want to turn to Jessica and sort of tack on to a little bit of what you were just saying, and leads into the next question that I had, which is about monitoring of what might be happening as the unwinding begins. And I think that's a great place for Jessica to talk about some of the challenges and maybe what might be happening at the federal level with monitoring of the unwind of what happens as states begin the unwinding.
Sure, and I mean, first, I would completely agree with what Kate and Tia said around about volume being a biggest challenge, but also to tie it into capacity at the same time. I think the survey itself shows the high vacancy rates and lots of work ahead for states at the same time that there's a lot of, there's limited staff capacity, which is not unique to Medicaid agencies. That said, I take comfort in all the work that states have been doing over the past couple of years, and really think that we are in a place where with all of the work that states have been doing, Medicaid is better positioned now for the work ahead than I think has ever been the case, and really also in the longer term to ensure that minimize churn and continue the focus on the enrollee. To that point, though, and going to your question about monitoring, we intend to take a really multi-pronged strategy to monitor the unwinding as we move forward, using data, our ongoing state outreach and engagement in partnership with NAMD and others, as well as other information from stakeholders and those on the ground. You know, states have been reporting data to CMS for quite a while now, almost a decade, on a number of key indicators that will continue to be helpful to help us identify where there may be issues bubbling up, whether that's call center data or enrollment, application volume. And then the Consolidated Appropriations Act also required new requirements around things like the renewal outcomes and the disposition that CMS will continue to monitor and make public. And really just want to note that all of that work we are beginning now. And there are also new tools that the Consolidated Appropriations Act gave to CMS to follow up with states and ensure that where needed, we can implement corrective action plans where we identify potential issues. But really, the goal is to prevent that, which is why a lot of the work that is happening now is upfront to try and avoid any issues that may occur.
Great. I'm wondering, do Tia or Kate have anything on anything else on monitoring or identifying early warning signs of how unwinding might be going?
So as far as identifying, in Pennsylvania, the Department of Human Services has started sharing data like the number of COVID flagged or overdue consumers by zip code with stakeholders, which has been helpful. There's also an expectation that the data that is collected by states that is shared with CMS will be shared with stakeholders statewide for analysis and to monitor trends. Managed care organizations are also encouraged to share their data with community health centers and with providers to partner in educational outreach and efforts to make sure that those Medicaid patients don't slip through the cracks. And this data should really assist in identifying any issues that are taking place over the next 12 months of the unwinding period.
And I'll just add, this collection of data, the transparency around the data is critical to this effort as we look to roll that up nationwide. A piece that we feel that we can contribute through our association is the standing affinity groups to which I referred earlier will continue to meet on a very regular basis, often weekly. That's an opportunity for a closely held session among peers from a range of states, sharing information about best practice, but also challenge areas. And this will equip us to really raise up those themes, especially to convey them to our partners at CMS and really to act on those aspects that are presenting more obstacles for states. So I'd say those affinity groups are a really important convening forum. I would also say we in the association are very much interested in remaining in direct communication, collaboration with advocacy groups like the Georgetown Center for Children and Families to examine lived experience of members and also partners in the community around communication, the real-time experience they've had, and also how it can inform course shifts or ways of augmenting the approaches at the state level. So we'd really like to partner in that respect.
Great. And so last question before we get to a very long list of questions coming in through the Q&A is sort of a speed round on if there's one piece of advice you might give to either states or enrollees, or as we're about to embark on implementation of unwinding, what would that very strong piece of advice be? And Jessica, we could start with you.
I'll say, echoing our theme of don't wait update as it relates to contact information, open the mail, and as it relates to both states and partners, really just continue the work that is happening to ensure that people who are eligible continue to remain eligible.
Great. Kate?
Yeah, and in that vein, let's over communicate. I think redundancy is not a fear in this instance. It's really trying all available channels. I would just say, I hope people will understand that state officials who are responsible for operating Medicaid programs are deeply committed to retention of coverage, continuity of care for folks, and will be using every effort to ensure that that occurs. Sometimes presuming goodwill on part of folks who are operationalizing the program, despite a lot of real challenges of the type that we have surfaced during this conversation, that would be of great benefit.
Great. And Tia?
2 bits of information. One, to states, automate and share information as much as possible. And also for those who are on the ground and working with Medicaid recipients, contact community health centers and other organizations for in-person assistance for folks who are having troubles getting into or getting in contact with their Medicaid agencies or with their county assistance office, and report issues immediately.
Great. Well, I want to invite Tricia and Jen back up onto the panel, and we have many questions. I'm not sure if we'll get to all of the questions, a lot of state-specific questions, and I'll just say the report has many state-specific tables. So I think some folks are asking state-specific information, and we might not get to answer those questions on the webinar, but there's a lot of state-specific information in the report that we can direct you to afterwards. But we are getting some questions about staffing, and certainly the report highlights the staffing shortages and some ways that states are working to expand capacity. I'm wondering if anyone has anything to add about if there are any actions that CMS or other actions that states can do to highlight or to fill vacancies and expand staff capacity. So I'll leave that one open. Maybe Jessica, if you have anything from the CMS side, and then we could see if there's any other suggestions from others.
Sure. I mean, I would say at the state level, there are states are really trying to broaden, think about as the net of people who can support. I mean, there's the eligibility workers, and then states are working with many contractors. But in thinking about capacity and what is needed, I want to make sure that we're also thinking more broadly about the role that community partners, faith-based organizations, and others can play that is equally critical to helping people renew their eligibility. And that includes all the work to promote I think all the things that Tia talked about to make sure that people understand what is happening, as well as to provide on the ground one-on-one assistance through healthcare providers, community health centers. Health plans are also playing a critical role to help individuals update contact information. So even in cases where people can't necessarily serve as state staff, there are critical roles that everyone can play in order to support this work ahead.
Yeah, I'll wrap around and say, I think that's an excellent point about the amplifying effect of all those who are linking arms in this effort. I will say state programs are using every available tool. They are, of course, challenged, as are so many other entities right now, with the very low rate of unemployment and the challenge of recruiting for positions, especially with this enormous bubble of effort that they're responsible for presently. Folks are borrowing from other divisions. They're bringing back retirees, as Robin, you said, mentioned contracting for call center support, and that will continue. I think they're also examining the onboarding process for eligibility staff, smoothing that to the best ability, using apprentice models, and enabling people to become effective as rapidly as possible, even acknowledging the complexity of this work, and that often it is not cookie cutter, especially with folks who are non-Magi members. It is complex, so you really want to make sure people are equipped to handle the individualized determinations for those folks.
Great. We also have a bunch of questions about transitions in coverage, some on estimates, which I'm not sure if we can cover in this call, but I think we can probably touch on if there's anything that states can be doing to, or if there's any more details that anyone wants to provide on things that states can be doing to facilitate any transition in coverage from Medicaid to marketplace coverage for those who are no longer eligible for Medicaid.
I can jump in there and let my colleagues add. I think, yes, absolutely. And it's many of the things that we are already talking about, because facilitating transitions in coverage starts with completing the renewal process, completing the redetermination, ensuring that individuals have their contact information up to date, because the process is already in place for an individual who is found ineligible for Medicaid to seamlessly transition over to CHIP, if that's appropriate, or over to the marketplace or to Medicare. And there are a new special enrollment period opportunity at the marketplace that will facilitate transitions to the federal marketplace for individuals who continue to be eligible, also for individuals to transition to Medicare. There are many both state-based marketplaces as well as the federal marketplace that will be doing active outreach to individuals as well. So getting information up to date, emails, phones, other contact information is critical, not only to complete the Medicaid redetermination process, but also to support the transitions to other coverage and outreach there.
And Robin, we should note that in the survey, we did ask state-based marketplaces if they were doing anything special to ease transitions. So we would invite people to take a look at those data in the report as well.
Great. There's a number of questions here about people asking about people with specific health conditions and what states might be doing in terms of prioritizing or deprioritizing certain redeterminations. I know that states have some flexibility in how they can, and that's part of their plans, but I'm wondering if anyone has more insight that they might want to share about particular populations and what might be happening with the ways in which states are planning to move forward with their redeterminations.
Yeah, I would start by saying that I think states are very, very attuned to continuity of care matters for people with chronic conditions, folks with disabilities who are reliant on Medicaid supports to remain independent and employed. So there's a lot of attention, as you said, Robin, in the staging of the redetermination process, which coverage groups are renewed at which interval over the time period of redetermination. Also, states are exploring strategies. New Jersey is one of them, really to have specifically targeted outreach to those individuals through their usual source of care and also directly with members to cue them, especially if folks are not responsive to the mailed notices, and to wrap around with other means of communicating with people, notably texting. New Jersey set up a kind of fail-safe with a dedicated team around those special populations that I think is specifically oriented to maximizing the opportunity to retain coverage.
And I'll just echo a little bit what Kate said with information from the survey. We did ask states how they were prioritizing renewals. And we learned from that some states are planning to use claims data to identify individuals who are currently using services, and particularly people who are, in the middle of treatment or high users of services, to maybe delay their renewals somewhat, so or at least consider that as one factor in how they are prioritizing renewals. So I think states are cognizant of this issue, and some states are really focused on trying to make sure that people who continue to need access to care are able to get that during this process.
Great. Tia, maybe this one is for you. I think there's some specific questions here. We talked a lot about communication, but there's some specific questions about how folks are engaging faith-based organizations, churches, other community-based organizations, as well as providers. So what can we tell these organizations about unwinding, and how can they help?
So specifically, we rely on our Department of Human Services, and again, have partnered with the Department of Human Services and with Penny to really get information and FAQs centralized on the Department of Human Services website. So we're really pointing folks to those resources and information right on the website. And then on the ground, we're connecting and providing information, webinars, providing enrollment assisters at different locations, and really maximizing the partnerships that we have on the ground to drive folks directly to that one source of information so that we can all continue to say the same thing and folks know where to go for help and assistance. And then, of course, our state-based marketplace, which is called Penny, short for Pennsylvania Insurance Exchange. They're collaborating also with the Department of Human Services to send out information and notices that are co-branded to those who are likely ineligible for medical assistance at the end of the PHE. And it really just circles back out to folks and provides information for them to go directly to DHS's website, to go to the Penny website to look for in-person assistance. And then again, those folks who are on the ground are reaching across to those partner organizations to provide education to them where DHS and Penny's hands may not be able to reach.
And we also know that a lot of states have produced communication materials and toolkits that they're making available to community partners. CCF is tracking this in our 50-state unwinding tracker, and there are links that folks can access there to get those documents. And some of it is really fabulous. It's an area that I've really been impressed with some of the state work in terms of those graphics and communications and social media messages. There are a lot of resources out there.
One other question on the communication side is related to rural areas. So I'm wondering if there's any efforts or specifics that anyone might be aware of that wants to talk about outreach efforts to people in rural communities that might be different to target people in those areas.
So for the community health center aspect, we really stress meet people where they live, work, play, pray, eat, and shop. If you meet folks at those locations, that will be where they'll have the questions, and you'll be able to give them the information. So that speaks to urban, but that also speaks to rural. Sometimes there's not broadband available. Telephone service may not be the greatest, but there are community health workers who are on the ground who can share information as well. So again, wrapping your arms around the folks who are in the communities that you serve is what community health centers do. So we're providing them with the information that they need.
I was gonna jump in and say Tia said it very well. I mean, I think, and these are the types of things that I think we're trying to highlight. There are really many tools available for states, and many states are taking them up to help ensure that all communities, whether it's rural or urban or limited English proficient, or populations that may not otherwise be reached by broad-based messaging, are able to also receive the communications that are needed to move forward. And a lot of that involves partnering with local communities, whether it's the faith-based organizations, health plans, or other areas where where individuals access information, and using them as assistance partners to be able to get this message out, and also actually do the support to help individuals complete the renewal process.
And I would just add, I think this is an inspired overview of the myriad touch points that are possible. One aspect that I think we really talked about today is just winnowing the message, the central message that we need individuals' contact information. We don't want to exacerbate the burdens on members by kind of shifting the responsibility for the entirety of understanding the redetermination process. That squarely remains situated with the state programs, but we do want to alert them to that very, very simple proposition of making sure that their contact information is up to date. So I think all states have striven to focus there and to kind of really hone that message, to kind of shuck away all the other types of language that usually come with a Medicaid notice, which is tends to be pretty opaque and impenetrable.
Great. And I think the last question that we have time for, I might just ask if there's any lessons that we think we learned from this continuous enrollment period that we might think about in going forward with the unwinding, that might be important both at implementation for enrollees and for policy as well. So I think anyone could jump in to answer that kind of question, things that we might take away from this last 3 years of this process as we look forward to the unwinding.
I can start very briefly, and I touched on this a little bit earlier, but really there have been so many advances that Medicaid agencies have made in both the partnerships that they've done, the adoption of strategies that they have taken, and really a focus on the individuals who are enrolled through things like contact information updates. Tricia mentioned the social media and other outreach that has historically not been so prevalent in the Medicaid space, and really think that this process has laid the foundation for states to continue that work, which ultimately will improve continuity of coverage for eligible people, transitions of coverage for individuals who are no longer eligible, and make for a more efficient and effective management of the program.
Perfect.
I would say we've had, an absolutely fertile period of time in which to examine the myriad impacts of continuity on outcomes and experience for folks. And I think that is enormously important as states will be implementing continuous coverage for children and hopefully influence the pace of adoption of it. And also the option for postpartum coverage for mothers, which are non-exclusive examples of smoothing the process of the redeterminations for folks who would otherwise be highly vulnerable to discontinuity of care and potentially worse outcomes if they are not retaining Medicaid coverage. So I think this is a really important leaping off point to consider those mechanisms within the program and potentially to build on that going forward.
I would also like to say that during any process, especially during this unwinding process and thinking about it for the past 3 years, we should make decisions and help to make decisions for consumers, but we also need to make these decisions with consumers. So the consumer voice, their opinion, what works best for them is always the best sounding board to ask questions, to work with the consumers and with the patients to find out what they like and what they need.
And Robin, I would emphasize the importance of states maximizing their use of technology. We know that states that have high shares of automated renewals have less manual processing to do that goes hand in hand with staffing shortages. And in fact, by maximizing technology, we can reserve those human resources for giving the human touch to the folks that need it.
Great. Thank you so much. We are out of time, but clearly there are many more questions to answer and a lot of work to do. But as we begin the unwinding process and get into March Madness, I think we all learned from this briefing that there's a huge amount of work to be done, and that unwinding will be an enormous undertaking. We also know that the policy choices and the implementation of those policy choices will vary across states, but collectively have really important implications for coverage, including how well people transition and how many people remain eligible or continue to be enrolled in the Medicaid program. So I want to wrap up and thank everyone who joined the webinar, and also thank the panelists for a great discussion and sharing their time and expertise. I want to remind everyone that the slides and a recording of the webinar will be available later today, and you should get an email about that. So I think that concludes our webinar. Thanks so much.